My talk is focusing on non-communicable diseases, which Arpana referred to in her talk, and also how COVID is going to influence this. And I'm presenting it in a way that what was NCD before COVID, what is NCD during COVID, and what can it be beyond COVID-19. So starting with the non-communicable diseases before the onset of COVID, how was it and what was happening in the world? Look at this. It is premature mortality which we are concerned about, because as people are getting older, naturally the most common cause of death will be one of the non-communicable disease. But in the most productive phase of life, which is 30 to 69 years, every year 15 million deaths happen in the world. Imagine 15 million deaths, that means almost 40,000 deaths a day. If Daily Mail and New York Times and Financial Times are presenting that 40,000 deaths in the world today from non-communicable diseases, what will it be compared to in scale? Of course, it is not rapidly transmissible, but in terms of scale, it is no less than a pandemic, except that this is a hidden pandemic, and what we are seeing is a very visible pandemic. And the hidden pandemic is also in slow motion compared to this abrupt onset of a pandemic, which is making the world like what we are living today. So I think that is my first pitch, is to say that this is no ordinary small time condition that, okay, some people have diabetes, heart disease. It is not. This is a major killer of people in their most productive phase of life, and most of it is preventable. WHO looks at the probability of dying from one of the 4 major NCDs, which includes cardiovascular disease, cancer, diabetes, and chronic respiratory disease. So it is almost varying from 10% to 30% from one extreme of the countries to the other extreme of countries, with countries falling in between, which actually shows that it is possible. So that this disparity actually shows that it is possible to reduce the premature mortality from NCDs. But most countries are not able to do that, and still losing a lot of lives in the most productive phase of their lives. So why do all these things happen? This is the standard depiction of life cycle that we all know, from infancy to childhood to adult to old age. And we are very comfortable in understanding life that way. For your convenience, let me put it in a very different way. If you look through bottles, what will it look like? So the first 2 years we are in bottle feed, then we are in sodas, and then the world is in alcohol, and finally in the hospital in an IV bottle. And it is all market driven. It is all profit driven. And this actually shows why we have so many non-communicable diseases and what are the primary influence of the risk factors in the world that we are living in today. But education is good, but education is not enough to change behavior. Behavioral interventions have to happen, have to translate to behavior change. And that is why public health is so critical to break that wall, which is through policies, legislation, regulation, taxation. Essentially, what we should do is make healthier living easier living. But now healthier living is more expensive. To live healthy is quite a troublesome effort now. But what we should do is, sorry about that, there was something going on outside. So what we should do is we should try and make people's life easier for healthier behavior change. And that needs a whole of government approach. And it has already been mentioned by Arpana as to how inequalities are created. So that is why I wanted to look at this slide. If you look at poverty and NCDs, it is a very interesting combination. Poverty in the high income countries is very different from poverty in low income countries. And when people are poor, they are more exposed to risk factors. That is very, very clear when you look at tobacco or obesity or anything. Lower socioeconomic strata people, especially in relatively higher income countries, are much more affected by all the risk factors for NCDs like junk food or tobacco or sedentary habits. And when they get NCDs, they actually get much less care for various reasons, as we know. And that leads to a huge impact in the family. So it goes into a perpetual cycle from which it is very difficult to get out. So that is why how inequality affects NCDs and how NCD promotes inequality. So it needs a very concerted, targeted effort to address this. So how are we faring in the world? Because UHC is the new mantra, the universal health coverage. So the WHO UHC coverage report in the last 2000 to 2016 period shows that there has been substantial improvement in coverage of infectious diseases. I think mainly due to the Global Fund supported HIV, TB, malaria programs. But the non-communicable diseases coverage has been almost a plateau. That means much more has to be done in terms of improving the coverage. But it is easy to say do more, but look at our health systems. I always equate that to the beating a tired horse, which is very clear that the system is almost like that. It just cannot handle the current burden of disease. The wheel is broken, the people are not there, the engine is weak. And so we just cannot sort of beat it with new things and new policies and new interventions and say do everything. So I think we have to really, really change the engine. We have to change the system. And I like the quote that Arpana said, if you do the same thing, you will get the same results. If you want to get different results, you have to do things different. And again, what is the current capacity? So WHO did a global survey recently and found out that if you look at major conditions like renal dialysis, retinal photocoagulation, stenting, you can see the classical gradient in low income, lower middle income, upper middle income, and high income countries. This is the availability of these services in public health sector in countries in these income groups, and it's very evident, and we know that is the reality on the ground. So what did we do? At least let me also put on a positive spin. So we just took a condition like hypertension, and it has got a series of hurdles. The diagnosis is not there, the treatment is not adequate, the continuity of care is not there, resulting in very poor control rate. Globally, only 7% of people who are on hypertension treatment gets fully controlled. Imagine that. So that is where WHO with partners developed a technical package called HEARTS. And the HEARTS package provides the various elements for scaling up primary health care with a focus on hypertension. And within 2 years, we could already show that in all the countries, it is substantially improving hypertension control. And the package is going to be widely expanded as a model for primary health care, which again emphasizes that primary health care, which people usually equate to immunization or maternal child health, has got a major role in making non-communicable disease prevention, especially acting as the gatekeepers so that they don't end up with end organ damage. Now, what happens during COVID? So COVID has suddenly come in, it changed the global context in every aspect of our life. One of the first things that people noticed are that in addition to elderly people, people with cardiovascular disease, respiratory disease, or diabetes do have a high susceptibility to get severe illness and or also for death. So that itself sort of brought in the interaction between a communicable disease and non-communicable disease and showed the world that how an uncontrolled pre-existing condition like a non-communicable disease can really make adverse outcomes even in a communicable disease. So I was thinking it is almost like a pandemic on a pan-NCD demic. So there is also the NCD pandemic going on, and then we have the COVID pandemic on top of that. So look at Italy. Out of the people who have died in hospital, 70% of them had hypertension, almost 32% had diabetes, 30% had ischemic heart disease. And it was also shown in Spain, China, USA, and all other countries. And the high mortality in older age people is also a result of not being old age, because they also are likely to have very high proportion of NCDs, as age is the single most important risk factor for non-communicable disease. There are also studies emerging that even high body mass index is making people susceptible to severe COVID. The series from China clearly indicates that the odds of dying is almost, the ratios are so high. It's 5 with chronic obstructive lung disease, 21 with coronary heart disease, 2.8 with diabetes, and 3 with hypertension. I think the multivariate analysis does not pick up that, maybe because of the high collinearity of the various parameters that are put in. But it's suffice to say that NCDs are a major reason for the high rates of death in COVID-19. WHO has recognized this and issued operational guidance for continuing services to look at different methods of ensuring that treatments are not broken for cancer or for renal dialysis for acute asthma. And many countries have taken up and ensured that continuation of service is made possible. Two parts of the world have reasonably addressed COVID-19, and it came, I'm sure you must have seen in different global media. One is Vietnam, the other is the state of Kerala in India, where I come from. And what is the secret for that? The secret is quick and efficient public health systems. That is what made the difference. There were enough boots on the ground to test, trace, isolate, quarantine, to help in various forms of social support. So it is an overall effort by the community with a well-empowered health system with adequate capacity is what makes the difference. I think adversities also bring up good things. I think the introduction of telemedicine in many countries is a very good thing that has been not widely used before COVID-19. There are even examples of the fire force in a country which is delivering cancer medicines and nice triaging, which are still applicable. I think even in a non-COVID situation, the crowded hospitals in many countries could actually do a good triaging system. So all these things have come up during the COVID, and some of them can be taken beyond. So my last section is to look at what can we do with NCDs beyond COVID-19. So let me also start by saying that the World Health Statistics, which was released yesterday, shows that the decline in premature mortality is much less than what it has been from 2000 to 2010. In the last 10 years, since 2010, the change has slowed down. And what happened to the risk factors? The three main risk factors, alcohol consumption per capita in liters in people above 15 years and age is not going down, plateauing, maybe even increase in many parts of the world. Tobacco seems to have gone down and obesity is increasing. So the three drivers of NCDs are not within full control. So if we restart, we should restart with more features, equity and security. So we should build back better, sustain and expand good practices. Person-centered care has come out as key even in preventing COVID. And we know that empowering people can make changes. I think this 3 or 4 months of COVID has taught us a lot of public health actions and principles and activities which we were waiting to see for randomized controlled evidence, but the evidence is in front of us. Social support is essential, and countries which have provided social support to quarantine people, to migrant laborers have really made a big difference. Maximize mobile and digital technology. See how fast all countries of the world have immediately put in tracking app in their phones. Why don't we have tracking apps for diabetes and hypertension? Many countries have made chronic care easier. So I think going forward, we have to look at the NCD kiosk. I was looking at the kiosks for checking for COVID in many countries. Why don't we convert them as NCD kiosks so people can walk around and then get their blood pressure checked or blood cholesterol checked from these kiosks? And then secure financial protection, and ultimately we have to measure impact. People always say behavior change is not possible, as I also started by saying at the beginning of my talk. But look at this, within 3 months, we changed the behavior of every human being on the planet, whether it is staying 2 meters away, putting a mask, not touching, not hugging, everything could change. I think a threat perception would have changed it, but also it is possible that behavior can be modified and if with appropriate intervention. So this is very much applicable to non-communicable disease risk factors. For NCD management, WHO is working extensively in primary healthcare. As I said, that is going to be our focus. That is going to focus on for the major NCDs, and many of them can be controlled. As again, that is one thing that we have seen during COVID, that people can be given longer duration of medicines. People with diabetes and hypertension may be managed adequately without the multiple hospital visits, and we have the appropriate tools also for that. But we have to again redesign the system. If you do the same thing again and again, we'll get all the same results. So we'll have to assess service delivery model with triaging by which NCDs are identified and managed and appropriately followed up with good counseling services. It is happening. There are parts of the world where primary health care, even in low resource settings, are going to look like this with all the necessary support systems and equipments that are needed. We should go in for simplified protocols. I think even in the COVID also, we see that when we are given simple, straight instructions, people follow that. I think one of the difficulties in NCDs is the treatment by fashion. Whichever is the fashion of the week, then the medicines change. But I think we should go into standardized, simplified protocols, which will make treatment effective, which will make access to medicines more available, and also will have an impact. So going forward, we have to have an impact in countries by putting NCDs into PHCs and into benefit packages of UHC, which with the fundamental premise of equity and quality, which is riding across all the development of benefit packages. The vertical programs, the heavily funded global fund activities of HIV, TB, and malaria and sexual reproductive health can certainly bring in NCDs because it is very much related. And as we have seen with communicable disease, COVID and NCD, it is very much related. We have to prioritize taxation of tobacco, alcohol, sugar, sweetened beverages, and get into a series of highly specialized programs which will have impact. And here is one example of WHO's work towards this. This is the WHO Elimination of Cervical Cancer Initiative. This is one NCD we can eliminate maybe in our lifetime, maybe in another 20, 30 years, we may see substantial reduction in cervical cancer through three major things. One is through HPV vaccination, and second is through screening, and third is through early diagnosis and treatment of cervical cancer. So these are the kind of ways that by which we should be able to integrate multiple interventions and lead to impacts. And as I said, all the expanded programs of tuberculosis, immunization, mental health, maternal health can certainly get TB, diabetes, chronic obstructive disease, everything into them so that we don't have to have this vertical programs anymore. There may be certain specificity is needed, but we can certainly add on NCDs into that. Finally, how do we approach patients? Again, COVID has taught us that it is not just the ventilator, it is also the human being attached to the ventilator who is going to suffer. So we should have more of conversations. We should have more of chat scans, as I always say, and not just depend on technology. We should be very honest in communications because we have seen that the human being goes through a very difficult situation, whether it is COVID-19 or renal dialysis or an acute myocardial infarction. So we need a very simplified high-touch approach in the sense we have to involve the family and come with realistic goals. And quality of life and quality of care is more than just saying the numbers that we are treating. To do all this, it is not easy. So WHO has come up with an implementation research plan because many of these interventions that I'm just speaking through slides sounds okay, but on the ground, it is a different reality. So I think there has to be substantial implementation research and delivery science if we really want to make these interventions applicable on a larger scale. And how do we measure? We measure with mortality and morbidity, the prevalence of risk factors, and the national health system capacity in terms of cervical cancer screening or access to HPV vaccination or access to medicines. So I'll stop with that. What I wanted to say is that the difference between communicable disease and non-communicable disease are fading. One is a manifest epidemic, one is a hidden epidemic. That's all the difference. Public health and primary care are priority to control both these pandemics. And the importance of public health, human resources in terms of quantity and quality have really come up in all countries of the world. And that is where we should have substantial investments. And primary healthcare is the way to do that. So thank you very much. That is my email address if you want to contact me. I want to end by saying that the impossible is possible if you want it to be. Thank you very much.
Thank you very much, and a good message to end on there. So we've got a few questions come in. So the first one, low and middle income countries often focus a lot on communicable diseases and find NCDs much more of a rich person's disease. How do you think that we can overcome this barrier?
Okay. Um, Thank you, Greg. Thank you for the question. I think this has been a challenge for quite some time, that NCD is a disease of affluence. But as I have shown, even low and middle income countries are faced with the prevalence of hypertension, which is almost like 1 in 3, diabetes, sort of 1 in 5. That level of prevalence is there. Obesity is increasing in low and middle income countries. And the complications like acute myocardial infarction, stroke, everything is so high. So when we have conversation with the senior officials of low and middle income countries, most of the time it starts with, oh, one of our colleagues had this particular NCD, or somebody. So it has become a conversational language. It is not anymore an alien condition. Even in the lowest income groups, there is substantial impact of NCDs. The other thing is that the general perception is that it is to be managed with very high-end settings with glass and steel hospitals and CT scans. But once we communicate to the low and middle income countries, look, treating hypertension is one of the easiest things to do. It is very easy to diagnose. Treatment is very easy. Drugs are all generic, and you get substantial improvement in health. That actually changes the conversation. Plus, we also have to have the voice of people living with NCDs. I think if you look at many of the communicable disease, the impact actually got generated when people affected with HIV or people affected with TB and the civil society really put up this as a major challenge in front of the governments. I think, again, along with being hidden, it is also silent epidemic. So that is why the forums like this and the public health professionals have to bring out more data. WHO has got a stepwise survey called NCD Steps, which actually brings out the prevalence of NCDs and its risk factors. We have it in about 80 countries, which you can see on our website. So a combination of data, high-level advocacy, and civil society engagement, along with realistic solutions, will make the change. Thank you.
Thank you. And another question here, non-communicable diseases are underfunded already. Do you think that this will get worse due to the focus on COVID-19?
To some extent, maybe, but I think this is a long haul. So a short injection of external funding alone is not enough to address NCDs. So the national systems have to put in more money. All what I am thinking is maybe because of COVID and the importance of health, many countries will increase the total GDP's proportion on health, which is one of the fundamental requirements in my view to improve overall health and primary health care. The NCD as such, as has been rightly pointed, has not been heavily funded. So there is no immediate change in the funding, but we are also looking at other ways of partnering with various sectors to support NCD services in countries. And we think that domestic resource mobilization and higher proportion of funds being allocated to NCDs will be the only long-standing solution to this. Thank you.
Thank you. So in your talk, you mentioned telemedicine. Post-COVID, what do you see as the opportunities and challenges for this form NCD?
Well, that is one thing I think will be, in my view, is going to make a very big difference. Because if you look at non-communicable disease, take diabetes or hypertension or chronic obstructive lung disease, it is a lifelong condition. It doesn't go away in 1 week or within 1 month. So that means this person has to be dependent on the health system for a long period, which can completely be offset by having a communication mechanism which is reliable, which is stable, which is supported by the legal and regulatory frameworks of the country. So I think that for most of the chronic care condition to be followed up, we can first of all reduce the number of visits to the GP. If the GP has got a very good rapport and the patient understands what needs to be done, that will make a very big difference. Second is that the telemedicine itself is also going to be very effective in looking at drug supply shortages, because many of the chronic diseases end up in complications and end organ damage because of disruptions in treatment. So once we have a telemedicine system, we will know what is the sort of stock out, who is having disruptions, etc. The challenge is, of course, it needs still capacity, because An app and a phone alone will not make all the difference. There has to be people at both ends who are empowered and equipped to operate the system. Thank you.
Thank you. You also mentioned how the behavior of everybody on the planet has changed in such a short period of time. How do you think we could get rapid results like this for NCD's behavior change?
I was really impressed with many of the changes that has happened, as I said, but it is also happening to tobacco. I think people were homebound and not able to sort of smoke with the lockdowns, and there was an immediate interest in tobacco cessation. WHO is setting up a tobacco cessation facility with access to drugs and other measures for tobacco cessation. So I think a bit more serious engagement by governments into regulating some of those things, regulating the access and the supply and the marketing can lead to changes. I think as we have seen that changes are not bad. People are willing to change if they are given the right motivation and the right enabling environment and the right support. I think that is one thing that is teaching us that junk food or harmful use of alcohol or tobacco, rather than paying lip service and providing some advertisement on not to do this or giving some general guidance, if it supported with good mechanisms, a clear regulatory pathway, people will change behavior, because ultimately human beings want to survive. And if they realize, as in this situation, that this is going to affect their survival and this is the way to improve survival, then they will do it.
Thank you. And finally, before we move to Richard, there's one three-pronged question. What would be the one priority you would want the world to come together to tackle NCDs? Will we see universal healthcare, especially for NCDs, in our lifetime? And how can we influence big business in the fight against NCDs? Oh,
that is three questions for another 1 hour. But I think tobacco control still remains as the single most important preventable risk factor for NCD, and tobacco control has to be really taken to scale, and it will have immediate impact in our lifetime itself, because unlike many other risk factors, if a person gives up tobacco, within seconds and hours that the impact will start manifesting. Within 10 years, you will start decline in mortality. Another thing is vaccinations against NCDs, such as the HPV vaccine, again, an NCD that we can eliminate with good coverage. UHC, yes, UHC is the mantra, but it has to be very balanced. I think all of us know about the UHC cube, which looks at the coverage and the conditions to be covered and the financial protection to be offered. I think that is the way to go. We should have very measured, optimized set of NCD interventions within UHC, so that they can be really beneficial and have the UHC coverage scaled up massively in a very short time. In fact, if we scale up UHC coverage massively, we will have an impact. Already, if you look at cardiovascular disease in high-income countries, it has dropped massively. The most common cause of death in many high-income countries is cancer now. It's not heart disease as it used to be in the last century. So things are already changing, and it is possible. Big business, again, nobody is against business practices, but can we do big business by producing healthier products? Why not? Why should we have products which are adversely affecting and make profit out of that? Make profit out of products. And so regulation and reformulation, advertising healthier products more, incentivizing the consumption of healthier products, all that is possible, because it's only a question of changing the manufacturing practice. And if we keep people's health as the primary motive, and again, let me tell you that the existential threat is what has made the world to change, and we have to ensure that such a threat doesn't happen. But there are existential threats like non-communicable diseases, where big business, society, and governments have to act together. Thank you.